Rheum pathology, neuromuscular junction diseases, myasthenia gravis, and Lambert Eaton. All right, so main takeaway here is you probably know all of this already, right? Because M1 year, we got tested on it a billion times. But I'm just going to run through it because it's okay. It's not too high yield, not too low yield, but it's in yield. So first, it's the most common neuromuscular junction disorder, and it's autoantibodies to postsynaptic acetylcholine receptors, okay? That's the first thing you have to know. Another thing that they want you to know is kind of just the clinical presentation. You're going to have fatigable muscle weakness, okay? And that's going to present with ptosis, diplopia, all right? You can have dysphagia that worsens at nighttime, right? So that respiratory muscle involvement could be causing dyspnea, and then obviously the bulbar muscle involvement can cause dysphagia or difficulty chewing. The reflexes are spared, so you have normal reflexes, and remember that myasthenia gravis worsens with muscle usage. Okay, very key, right, to differentiate it between Lambert Eaton. Now, it's associated with thymoma, okay, thymoma and thymic hyperplasia. So one of the key tests would be imaging of the mediastinum to see if there's any thymic abnormalities because of its high yield association with thymoma and thymic hyperplasia, all right? And it usually resolves with a thymectomy, removing the thymoma or thymic hyperplasia. Just removing the thymus in general usually can resolve myasthenia gravis. Now, you could also give patients acetylcholine esterase inhibitors. What that's going to do, like pyridostigmine, okay, for example, what that's going to do is going to increase the amount of acetylcholine in the synapse, which can competitively compete with the antibodies, and so then they could push them out of the way, all right? Remember that myasthenia gravis is a type 2 hypersensitivity reaction, and it involves IgG autoantibodies, okay? So it's similar to good pastures in that fact. And lastly, myasthenia gravis can cause like reduced amplitude of motor end plate potential, right? Makes logical sense, but it's just a weird kind of physics question that they might ask you. Because you have acetylcholine receptors blocked, some might be open, some might be blocked, it's going to cause a reduced amplitude of motor end plate potential. Now let's compare it to Lambert Eaton. Lambert Eaton is very uncommon, but it's autoantibodies to presynaptic calcium channels. So if you have presynaptic calcium channel autoantibodies, then you have an inability for calcium to enter, which leads to an overall inability for acetylcholine to be released, okay? Now, you're going to see proximal muscle weakness and autonomic symptoms like dry mouth, constipation, impotence. But what they want you to know to differentiate it from myasthenia gravis is that two things. It causes hyporeflexia, whereas myasthenia gravis has normal reflexes. And then Lambert Eaton also is improved with muscle use, whereas myasthenia gravis worsens with muscle usage. Okay, and they want you to know that. It has an association with small cell lung cancer. We talked about that in the respiratory chapter. Okay, so that's Lambert Eaton versus myasthenia gravis. Relatively straightforward. Just know the differences between where the pathophysiology occurs, where the autoantibodies are attacking, and then know the difference between the reflexes and what gets better with usage and what doesn't get better with usage. Okay.